Metastasis-free survival is the period of time from identification of non-metastatic castration-resistant prostate cancer and then the identification of a metastasis on some sort of imaging modality. So it's the time between the 2 points. To date, metastasis-free survival has not made a big impact, simply because we have no data that anything improves that endpoint at this time. One of the benefits and hindrances of prostate cancer is that it's a very slow-growing disease. So there can be a huge amount of time between diagnosis of localized disease, PSA recurrence, development of metastases, and death. And that's great for our patients who have years to live. But when it comes to designing a clinical trial, it makes things complicated because we can't always wait 20 years for a result. So Dr. G did a study looking backwards at a bunch of other clinical trials that were done for localized prostate cancer and found that the development metastases predicted death from prostate cancer. So we could use this surrogate endpoint now. It's a much shorter time between treatment of the primary cancer and recurrence of that cancer than it is from treatment of the cancer to death. So it's a very important finding. It doesn't really apply to this case because we're looking more at the development of non-metastatic castration-resistant disease and the time to metastases. So it's a very different setting. But it does speak to the fact that perhaps if we could delay the time to metastases, we could help outcomes. It's not really applicable. The future use of next-generation AR targeting agents are likely to be used earlier in the disease. They are also very likely to be used in combination with other therapies. So in prostate cancer now, we have chemotherapies, immunotherapy, radiation therapy, and these AR-targeted therapies. And there's not a lot of overlap of toxicity between all these classes. So I'm currently doing a study of enzalutamide, which is an AR-targeted therapy, plus pembrolizumab, which is a checkpoint inhibitor immunotherapy, to see if the survival is improved compared to enzalutamide alone or pembrolizumab alone. I can see these agents being used in combination. I know of several ongoing studies where this is being done. We also need maybe third-generation androgen receptor antagonists that can overcome the resistance that the second generation causes. And so I think that we will find, or I hope that we will find AR receptor antagonists that can bind to different parts of the AR receptor